Assalamualaikum students. Today we are going to study the glycoprotein hormones. Thyroid stimulating hormone, follicle stimulating hormone and luteinizing hormone. These are the glycoprotein hormones of pituitary gland. They all are made up of two subunits. There is an alpha subunit and then there is a beta subunit. Now all the three of them have this alpha subunit which is common to them, and the beta subunit is specific for each and every one. So alpha unit is also common to the human chorionic gonadotropin, which is the HCG. So beta HCG is estimated as an index of pregnancy which is specific for pregnancy. Beta HCG is also a tumor marker for choriocarcinoma. So now we will be studying the different hormones in detail. Follicle stimulating hormone. So the beta chain of this follicle stimulating hormone and luteinizing hormone have 118 and 112 amino acids respectively. So FSH has 118 and LH has 112 amino acids. Each has several disulfide linkages which give the activity to these hormones. Now FSH brings its action by specific receptor binding by the secondary G protein mechanism and cyclic AMP mechanism. And both FSH and LH have acylic acid, hexose and hexosamine. So in female, as the name indicates, follicle stimulating hormone, it promotes follicular growth and it prepares the Graafian follicle for the action of the luteinizing hormone, and it enhances the release of estrogen induced by LH. So it enhances the release of estrogen induced by LH. So what happens is that follicle stimulating hormone is promoting the follicle growth and it is preparing the Graafian follicle for the luteinizing hormone to come and act on it and ultimately release estrogen. Okay. In males, it stimulates seminal tubule and testicular growth, and it also has a role in spermatozoa maturation. It cannot cause the complete formation of the spermatozoa because for that you also need the testosterone. So both FSH and LH must be secreted for normal spermatogenesis. Testosterone in males and progesterone in females are increased under the influence of LH. So FSH and LH are secreted under the effect of gonadotropin releasing hormone. This is like the common things between LH and FSH. Now luteinizing hormone. Luteinizing hormone is released under the influence of luteinizing hormone releasing hormone, which is also known as LHRH, and puberty does not settle in until the pulsatile strength secretion of LHRH is started by hypothalamus. So changes during the puberty include that because hypothalamus usually inhibits the LHRH. So the changes during puberty include the reduction in its inhibition of LHRH. So hypothalamus then stops inhibiting LHRH, it reduces inhibiting the LHRH. Then FSH rises during the follicular phase of menstrual cycle. The follicle stimulating hormone, it is helping in the growth and proliferation of follicles. So it is rising in the follicular phase of menstrual cycle. It peaks at the 14th day of the cycle and starts falling when ovulation occurs. So this is the rise and peak of the FSH. During the growth, it is rising till 14th day, and and when ovulation occurs, it starts to decline. Ovulation occurs as a result of positive feedback effect of estrogen producing the pre-ovulatory LH surge. So the FSH ultimately is helping in the follicular growth, and then there comes an LH surge where LH is secreted which in return secretes estrogen. So, high levels of FSH and LH fall during the post ovulatory phase unless pregnancy occurs. So, once they have secreted estrogen, they start falling if there is no pregnancy, okay. But if there is pregnancy, then these levels will be high, okay. So, metabolic roles of the luteinizing hormone, there is maturation of Graafian follicle, it stimulates ovulation, it stimulates secretion of estrogen, there is formation of corpus luteum for luteinization, and it can stimulate production of androgens also. Thyroid stimulating hormone, so this TSH, thyrotropin, has alpha subunit and beta subunit. I already told you that the alpha subunit is common to the TSH, LH, HCG and FSH, but beta subunit is different. Biologic specificity is due to beta subunit. Alpha subunit has 92 amino acids and beta subunit has 112 amino acids. So, the thyrotropin releasing hormone is secreted by pituitary gland and it stimulates prolactin in one instance, and it stimulates TSH secretion, thyroid stimulating hormone secretion, which in turn increases the T3 and T4 levels by stimulating all the steps of thyroxine synthesis that we studied in our previous lectures. Now, this acts through cyclic AMP. The normal TSH levels are 0.5 to 5 microunits per ml. The prolactin inhibitory factor inhibits secretion of TSH, and they are also controlled. The TSH is also controlled by the thyroid hormones itself, that is T3 and T4. The metabolic role of TSH, we know it stimulates thyroid hormone synthesis, it increases release of stored thyroid hormones, it increases the DNA, RNA content and translation of protein processes, it increases the breakdown of glucose, that is glycolysis, TCA cycle, HMP shunt and phospholipid synthesis. It is increasing all the synthesis of these, you are getting energy from there. It activates lipase to increase lipolysis. So, lipid breakdown is increasing. So, these are the metabolic roles of thyroid stimulating hormone. Then comes the prolactin. Prolactin is a simple protein which contains 199 amino acids with 3 disulfide bonds. It is secreted by lactotropes alpha cells of the anterior pituitary. We already know that it increases lactation on estrogen primed breasts, where estrogen receptors are upregulated, and it increases lactation. It increases the synthesis and milk protein and fat. Prolactin production increased by the thyroid, the TRH, and is inhibited by the prolactin inhibitory factor. So, hyperprolactinemia, where the prolactin levels are increased, it is a cause of infertility in females. So, you know, when you are breastfeeding, you don't get pregnant mostly while breastfeeding because of this prolactin levels that are increased during the breastfeeding. Then estrogen, this is the female sex hormone. It is secreted by gonads in response to LH and FSH that we already discussed. So, there are different types of estrogen, C18, C19 and C21 progesterone. They are produced by ovarian follicles. Follicular thecal cells produce C19 androgens, which are then converted to C18 estrogens by the granulosa cells by aromatization of the ring and loss of C19 methylene group. So, these are the structural changes that are taking place while this change. So, testosterone is converted into estradiol by aromatase enzyme using NADPH. So, there is reduction taking place. So, there are undetectable levels in prepubertal children. So, estradiol, most important, the estrogen one in liver, it's converted into estrone, and then in estrone is hydroxylated and converted to inactive estriol. The mechanism of action is this estradiol is bound to plasma sex hormone binding globulin. It binds to the receptors on target cells, and further it attaches to specific regions in DNA. Okay, and then through there the mechanism of action occurs. So, follicles under the effect of FSH ripen and they produce estrogen. So, estrogen level increases in second week of menstrual cycle. Level is maximum 24 hours before LH peak, and increased doses suppress LH release and act as contraceptive. So, you know that FSH and LH, when LH surge comes and estrogen is released, if there is more estrogen, it is going to suppress the LH release and it acts as a contraceptive, so that LH does not act on the follicles. So, estrogen acts on the uterus and uterine endometrium proliferation is taking place. The endometrial glands with progesterone receptor synthesis will occur, okay, will be prepared. LH, the level peaks are 16 hours before ovulation. There is an LH surge, which we already told you. Then there is ovulation. Then after the ovulation, corpus luteum secretes progesterone. There is a uterine secretory phase. The uterine secretory phase. Now, where will it go? So, if there is implantation and fertilized ovum, there is a different line of action. That is, LH acts on the maintenance of corpus luteum. If there is implantation occurring, the HCG takes over the LH function that is produced by cytotrophoblasts. So, HCG takes over LH function, implantation has occurred and pregnancy is like there, and HCG is there in the urine then. HCG can be detected 7 days after missing a period. If there is no implantation, hormone levels, as I already told you, FSH and LH then start decreasing and there is secretory glands denuded and you have this menstrual cycle bleeding. So, this is how estrogen acts on the whole cycle. Clomiphene citrate is a drug that competes estrogen for receptors in hypothalamus, thereby removing the feedback inhibition. So, then there are gonadotropin releasing hormone levels increase, there is increased LH and FSH, thus there is increased follicular stimulation and ovulation. So, clomiphene acts as is used in increasing ovulation in infertile females. Then there are more chances of pregnancy as ovulation is increased. Some carcinoma breasts are also estrogen dependent, they live on estrogen. Then you have to give some anti-estrogen drugs like tamoxifen, which block the estrogen receptors, and then cancer cells tend to die. There are different sex hormone disabilities. There can be secondary testicular dysfunction, primary testicular dysfunction, and delayed puberty, precocious puberty, primary ovarian failure, virilization, in which different hormones have different levels. And if there is abnormality of gonadotropin secretion, if it's prepubertal, there is failure to attain puberty, there is no secondary sexual characteristics, and failure to attain menarche. Post-pubertal deficiency, if there is, then you have infertility and loss of libido, you can become impotent, there could be just testicular failure, amenorrhea, ovarian failure in females. If there is excessive secretion, there is precocious puberty. And this is all about your glycoprotein hormones, and inshallah in the next lecture we will be doing the adrenal cortex hormones. Hopefully you understood. Thank you very much.